Good evening. I'm Danielle Salomon from the Australian Friends of the Hebrew University. Thank you so much for joining us for our very first webinar in our new series, The Impact Exchange from Jerusalem to Australia, where we bring together leading scholars from the Hebrew University alongside local Australian experts for insightful conversations on some of the key issues shaping our world today. We are so honored to be joined by Dr. Danny Brom tonight, Founding Director of Metiv, the Israel Psychotrauma Center in Jerusalem, and a former Associate Professor of the Hebrew University. Dr. Brom leads the Trauma and Reslience short course at the Hebrew University. This course has been running for over 15 years, equipping professionals and community leaders with evidence-based approaches to trauma and recovery. We all know since October 7th, Israel has faced unprecedented national trauma, prompting rapid innovation in research and treatment. In the wake of our own tragedy in Bondi, many in our community have been reflecting on the very real need for practical tools to understand trauma and to strengthen resilience in ourselves, our families, and our communities. This makes tonight's conversation especially timely. The more than 100 applications we've received for Dr. Brom's course this year are a testament to that urgency. Dr. Brom will be in conversation with Sydney-based counselling psychologist and clinical supervisor, Rina Taub. Later in the program, we'll also hear from Gabriella Bolel, a past participant of the Trauma and Resilience course, who will share her reflections and experience. We will aim to leave time for questions at the end, including ones about the short course on trauma and resilience. So please feel free to place your questions in the chat as we go, and we'll try to get to as many as possible. Dr. Brom, Rina, thank you so much for being with us, and we look forward to the discussion. Over to you.
Thanks so much. Good evening, everyone. Thank you for joining us for this really important conversation. Looking at understanding trauma and resilience, lessons from the Israeli experience. Danny, I've heard about you for a long time. I remember reading about your work with Naomi Baum around the time of the Second Intifada, and then to actually meet you in Yerushalayim, and now to be meeting you and speaking to you at this important time for us in Australia. So just to let everyone know, tonight's session is designed as a guided conversation. So what I'll be doing is posing some questions to Danny across several themes, looking at the trauma response since October 7, to survival mode, innovations in treatment, community resilience, and finally we'll be focusing, as Danielle said, on the overseas summer intensive for clinicians. Okay, so let's start, Danny, by starting at the very beginning. What first drew you to the field of trauma? And how did these early experiences shape the vision and mission that still guide the Metiv Center today?
Okay, good evening to everyone. It's a pleasure to be here, although I don't see you, but who knows, will I see you in Jerusalem? What has drawn me to this field is basically in my DNA, because my parents, after the Holocaust, during the Holocaust, they were in Switzerland, so they were relatively safe. But then they decided to go and live in Belgium and work with children who came out of the concentration camps and out of hiding. And that has always been part of the family. We later then moved to Holland. I was born in Holland, and there we lived in this environment post-Holocaust that consisted of people who were still very, very much preoccupied or occupied with what had happened to their families. So that is my story. My four grandparents, or three of my four grandparents, came from Poland and moved to different places, to England, to Switzerland. So it's basically in my DNA to think about what actually does all of this mean, and what can we do to make life easier for people who've gone through very traumatic events. Now, that is the long story. The short story is I studied clinical psychology and in 1979 finished my MA. And then there was an ad in the paper. They were looking for a young psychologist to start doing something in the trauma field that was not very developed at that moment. And I got the job. So that's the short story of my involvement in the trauma field. And that has led to the Dutch Institute for Psychotrauma. And then in 1988, I came to Israel, finding the field quite neglected here. Besides research, there was good research, but the field of treatment was quite neglected. People saying PTSD is not treatable. So then I did what I had done previously, and I set up this trauma center, Metiv. And since then, since 1989, have done a lot of work in the trauma field.
Thank you. That definitely resonates with me in terms of my personal background as well, being a daughter of a Shoah survivor from Hungary. And I think you probably know that the Sydney community also has a lot of people from that background. And I think probably some of the people here became psychologists were also inspired from that direction. And as you know now, many in our Sydney Jewish community are still processing the shock and grief of the Bondi Beach Hanukkah terror attack and the rise of anti-Semitism, which has been happening since October 7. At the same time, we've seen extraordinary communal support and value-driven responses. From your perspective, what are the first principles communities need to hold on to in the aftermath of such an event?
Yeah, that goes together with something that has been my interest in the past 10, 15 years, which is the whole concept of survival mode. Now, when I say survival mode, a lot of my colleagues, and maybe also part of you, basically say, oh, you mean fight, flight, freeze. And then I say, no, that is not what I mean. What I mean is what happens to the human brain and the human body when we are in severe danger. Basically, the brain changes physically when we are in severe danger. And getting into survival mode, as some of you or most of you have experienced at Bondi Beach or also hearing about it, you automatically get into that. We don't have to learn, and so we do a lot of work with soldiers, and they are really well prepared to go into survival mode and combat mode. And the basic question for mental health professionals is how do we help people get out of survival mode? The majority do get out and do not develop severe disorders. And that is always the optimist view that even Holocaust survivors, not all of them were looking for therapy, not all of them were in full-fledged post-traumatic stress disorder. Some of them were, and some of them still are. But the first thing to know is that the expectation should be is that people get into the ways of how to get out of survival mode. And we can help that. And that is what we have experienced here during the wars, after the wars, during the Intifada, and all the terrorist attacks we have gone through here. The expectation is very important. Sorry. So the first thing would be, and that is what we're also teaching, is how do you work with people who need to get out of survival mode if it's possible? We are really more or less waiting for what's the next thing that's going to happen between the United States and Iran. And everyone at this moment is very uptight and thinking of, how will that be? Our safe rooms are ready. People have bought water and food to put in their safe rooms because we're being told that that is not going to be a short thing.
Mm. Yeah.
So, so that is the basis. And when people stay in survival mode, in full-fledged survival mode, although the situation has changed, then we call it at some point PTSD, post-traumatic stress disorder. And then we get into the field of, okay, how do you help people with PTSD or chronic PTSD to get out of that? But the framework of survival mode theory that was proposed by Dr. Claude Taub in the United States, who passed away a few years ago, is to really look at that in a very natural way of how an organism knows how to connect with other people, as you have experienced also in Australia. When there is this danger, you pull together. You attach yourself to a group, and that gives some form of feeling of safety. And that is one of the things that we see in all of the traumatic experiences, that there's this strong bonding during traumatic events, during life threat. And so it's really important, and that's what we also teach, to understand and feel the survival mode in all of its different aspects. And it has a lot.
So the course will be looking at and exploring both the bonding and the positive aspects of that, but also sometimes when we need to move from it. And as you said, about what's happening right now, it's obviously often a dance because there's that need to hold on to aspects of survival mode. I wanted to just also, you mentioned about terrorism and moving into that. I know you've written extensively on the trauma of terrorism. What do you see as the unique psychological features of terror-related trauma? And how can these insights help clinicians working with communities affected by targeted violence?
Yeah, one of the aspects of terrorism is that you don't see it coming. That and our enemies have used that to, especially also to confuse us. Like there have been terrorists in Israel who have dressed up as ultra-Orthodox, as Haredi. And what we actually have to do once you experience terrorism, you look around and you want to know, who can I trust? And when you get this confusion, and that is being played by terrorists also to confuse us and see everyone as possible terrorists, then we're in trouble. So terrorism in general is not about killing more people. It is about making people really terrorized, being very afraid. There were times in 2002, 2003 that people in Israel didn't dare to leave their homes because buses were exploding, and in a cafe you couldn't sit safely and things like that. And when that happens, the ultimate goal of terrorism is then to get to the economic functioning of a country. And when people are afraid to leave their houses, they will not go out and buy, they will not go out and do nice things. And that gets to the economy. So our role then is to not see that as psychopathology, but to see that as a natural response that we need to say it maybe in a strange way, to dance with. How do you know that the same thing will not happen tomorrow or today? And that is, and of course, we cannot really promise anything. We had a lot of people coming to Metiv and say, I don't dare to go into a bus because there were buses exploding. And then the question is, okay, what do you say? We cannot, promise that it won't happen again. But then the question do you think that this is is this a decision of yours because it is dangerous to be in a bus? Or do you say, I'm fearful and it's okay to bring down the fear? And those are kind of decisions that we have to make together with our clients, and see how we do that, and not immediately go to when someone has, at this moment in Israel at least, when someone has a nightmare about having been in Gaza, everyone immediately says, oh, PTSD. No, the brain has to change back. And what we hear from soldiers is, we are wired for war, but no one taught us how to rewire when we get out of the war. And that is a major issue that we know now also from neurobiological perspectives of what is needed in order to let the brain rewire and let our bodies be able to get to quieter places.
Yes.
So our tasks are very different from, let's say, regular clinical practice. We are not there to just listen and think that whatever is important will come up again. No, we are there to create together with our clients safe environments or safe enough environments in order to people to start the process of getting out of survival mode.
Mhm. Yes, and I think, that presentation that you were speaking about with clients, I mean, we definitely had similar things here where people are making decisions about going to certain communal events, or can they take children to places, and navigating these sorts of things. What parallels or contrasts do you see between what Sydney is experiencing now and what Israeli communities have been navigating for decades?
Yeah, well, the upcoming anti-Semitism, a lot of people say now, I always knew it's just under the surface, and now it comes up. But it's always shocking to see that happening and to experience it personally. I grew up in post-war Holland, and I heard from all the people in the Jewish community of what they had gone through, but still, it doesn't become so personal until someone calls you a dirty Jew. And when that happens, your perspective in life shifts, or it gets broken down. Can I do what I want to do without being in danger? And then you have to readapt your perspective and also find meaning in what happens and what our personal experiences are. And that is a whole process, again, that mostly happens in more or less automatic ways. But what you see, certainly in Israel, is that the majority of the population did not get fully out of survival mode, but there are all kinds of things that remain stuck. And that is not only bad. For those of you who have been in Israel, you see how vibrant the Israelis are, how they're hungry to do more and more and more. And it has its bad aspects, like the way we drive our cars and are always looking for enemies on the road, which is quite dangerous, which I see also as a phenomenon that has to do with survival mode. But also you see how active young people are in our high-tech world, and we see a lot of the people in our programs. We have this Peace of Mind program for released soldiers, and they're really hungry to go out in the world and conquer the world. And there is something very positive in that also. And that
energizing about it. Yeah.
and
I
that
want
goes
to,
together
yeah.
with one more thing that goes together with the whole idea of post-traumatic growth. And that's also something we need to look into and see. It is not something we say you have to push people into, but a lot of people do feel that in a very natural way, that they say, it was a very bad experience, but I learned things from it. So hopefully that is also what can happen in Australia.
Yeah, and we want to hear a bit more about that and trauma across populations and responses. But just before we do that, can we just turn to the Metiv itself? And can you briefly describe for us Metiv's mission and the main populations that you service, like
Yeah.
people that come?
So setting up Metiv, it was really in order to, because, no, I'll start differently, sorry. In 1988, coming to Israel, very well-versed psychologist, psychiatrist told me, we know that you're in the trauma field, but we don't see trauma here in a psychiatric outpatient clinic. And in several places in Israel, that's what they told me. And at the same time, some of the researchers said PTSD is an untreatable disorder. Now, I had just finished my doctorate on 3 different methods for the treatment of PTSD, reasonably effective, not for everyone, but it was really a surprise for me coming to Israel that that was the opinion. We don't see it here, and it's untreatable. And so setting up the trauma center was really in order to create a movement in Israeli society to be more aware of what happens, because of course they were not seeing it, and I did some research about it and I totally agreed with them. They don't see it, but it was there under their noses. As long as you don't ask, you don't hear. Trauma requires an active approach because, especially those people who are stuck in post-traumatic stress disorder, they are avoiding the topic. And rightfully so. Why would you, punish yourself and get totally overwhelmed by telling your story? So I brought over all kinds of people to teach here. We started services, and it took time before it started to become a popular topic, and that everyone now wants to learn trauma therapy. So our mission statement is really to create programs to see which populations are not being treated well at this moment, develop, test them out with research, and then get them out into wherever it should be. So Metiv at this moment has 5 different areas of activity. One is an adult clinic, which is partly for the Ministry of Defense. So at any given moment in the building we're in, we're seeing about 300 to 400 veterans with full-fledged post-traumatic stress disorder who we are treating. And there's also a civilian clinic for people having gone through either terrorist attacks or traffic accidents or abuse in families. So whatever you don't want to go through, you'll find here. The second is the children's clinic. That is always a difficult issue because in traumatized societies, there's very often an attitude saying children are okay. And during survival mode of a whole society, children become very obedient. They don't want to stir up more. And even in Israel, that happens when you see children who are mostly quite wild and loose in Israel. Suddenly, they become very obedient, which is very nice, but it's not very healthy because they're keeping a lot of their stuff under. So the child clinic is not only a therapy clinic, it also has some community programs. Among them, a program called Namal for early childhood, where there are play groups for parents and 2 and 3 and 4-year-old children. And we've developed that in the past more than 20 years, first in the south, in Sderot, but now basically in all kinds of places where that is being done. And the second program that I'll mention is the PANDA program, which is a program for school-aged children to teach children emotion regulation. Because, as you know, Israeli society is not very regulated. If you look at how our Knesset members are talking to each other, or all in all, how Israelis talk to each other, there is always this tension. And so if you want to do something about it, why not start really early? And that is what we're doing. This is a program that is being done in schools, where, first of all, the teachers are being instructed on what is emotion regulation, what is resilience, how do you boost that in children, what can you do with them, and then also group interventions for small groups with children who are more dysregulated, and they get this group intervention. And for those who are still then in trouble, we also have, of course, the individual therapy. So we are always looking at creating comprehensive care models where you do something for the whole population. You then think about those who need more, and at the end of the day, also for those who are most affected by the situation, who might need individual attention. That is the children's department. The third thing is a large program called Peace of Mind, in Hebrew, Masa Shechur. This is a program we started in 2007, after the Second Lebanese War that happened in 2006, when we saw that basically you come out of a war, you come out of military service, and then no one asks you, what did that do to you? This was just the Israeli society saying, just go on, you're now free, do whatever you want. But then we saw how many of these youngsters basically flee to faraway places and do a lot of drugs to try and regulate themselves. And we started to think about a program of helping veterans to get out of survival mode and regulate themselves and think about, what does this mean for me? So that's a program where we take combat units, a team of between 15 and 20, 22 people who had been fighting together, had been in the army together, and then 5 years, 10 years, sometimes 20 years, because it didn't exist, come to us and say, can you do that with us? And so that slowly built up to what it is this year, where we hope to do about 70 groups of this program. In the middle of that program, we take the group to a Jewish community wherever in the world, from Sunday to Sunday for a week, in which we do very, very intensive group work. And also, what is also helpful is they then are being hosted in the homes of people in the Jewish community. And that helps also with creating meaning of what the Israeli army has been doing and is doing. And for a lot of Israelis, it is really a surprise to understand that this is not only, for our strange country and politicians, but this is something for the Jewish people. And that helps with creating meaning. Two more things that are in our area is, one is training mental health professionals. We've trained literally thousands of mental health professionals in the country, in different parts of the country, in the past 2.5 years. But also we've done a lot of this before. And the last thing is research, because we are a non-governmental organization, and we know that our main contribution is not only treating another 100 or another 1,000, another 2,000 people, but it is creating knowledge that can be transferred and taught to others, both in Israel and outside of Israel. So that is our whole package of what Metiv is.
Thank you. I know people are really keen to hear more about the research. Just before we go to that, though, just to kind of hover a bit more on the Peace of Mind program, why do you think it's so effective in soldiers processing the combat? And also, you mentioned to me when we spoke about it before that it really ensures, like this model that you've created ensures that no one falls through the cracks. So what is it about it, do you think, that allows that to happen?
Well, what we have added to that Peace of Mind program is that whoever needs, so all participants fill out questionnaires before and after and follow up. And that is in itself not only research, but just also our wish to follow how they're doing. And they're always, in a group of 20, there are always 2 or 3 who are in full-fledged post-traumatic stress disorder and need treatment. And within the frame of this program, of the Peace of Mind program, they then get referred to our network of therapists throughout the country to get individual treatment. Now, one of the difficult things to know is that the treatment of post-traumatic veterans in the world, with all of our evidence-based treatments like cognitive behavioral therapy, cognitive processing therapy, EMDR, somatic experiencing, prolonged exposure, all of these basically help only about 35 to 40% of the people who go into therapy to get out of their PTSD. So at least 50% need something else. And sometimes I joke about, and I'll ask you that question also, what does a psychotherapist do when his treatment doesn't work? Just ask yourself, what do you do when the treatment doesn't work? Well, mostly, and I'm not different from other people, you just continue doing the same and hope that something else will happen, which is quite near the definition of neurosis. So we have been thinking a lot about that. How can we boost the effectivity of our therapies? So two things came out of there. One is that we now have a second line of treatment, which is the MDMA-assisted psychotherapy, which we are doing, and there will be a full day in the course about that, about how we do that. And also, we do that in the frame of research, and we also have basically developed a parallel treatment with the same intensity. In the MDMA-assisted psychotherapy, there are 8-hour sessions with 2 therapists. And that happens 3 times during a 3-month period. So in our parallel therapy model, we also do that, but without the MDMA. And we are just only beginning with that. We've done 14 cases until now. And until now, we don't see a difference between the 2 treatment models. The psychedelic treatment has become a buzz in the world, and people are sort of became believers in it because you see amazing results, and I'm seeing them myself. Then the question becomes: is that really the psychedelic medicine, or is it 8-hour sessions that really does something different? So we are looking at that and to see how do we handle this. The second thing we're doing also in order to try and boost the first line of treatment is adding on alternative strategies like acupuncture or massage therapy or breathing groups that we do in parallel to the so-called regular treatment. And we want to see, can that boost the effectivity? And those questions are always with us, and not just doing more of the same, but seeing what our contribution can be also to the knowledge in the field.
Yes. So there are other areas of research as well. I know that is definitely the buzz area, and I'm sure everyone was really fascinated with that and the idea that you can have the same results without the psychedelic drugs, and looking at alternatives to enhance the work. You also mentioned a couple of other areas of research that I think people are interested in, the moral injury, neurofeedback, and a comparative study of somatic experiencing and EMDR. Can you just tell us a bit more about what are the questions that are driving these programs, and what are the early insights that are emerging from your research?
Yeah, so let me start with somatic experiencing. We all know that if you think about a bad event that happened to you and you bring the memory up, the first thing you notice is your body goes wild. It's really like Peter Levine, who invented somatic experiencing, says trauma is in the body, and I very much agree with that. And it's of course not only in the body, but there is a very gentle and I really have come to appreciate and love the the approach that basically lets people work with their own body and not be afraid of what is stuck in the body, but create a situation in which the body can release the excess energy that is stuck in the nervous system. So it's of course nice to love an approach, but then the question is it really more effective or less effective than other treatment methods? So what we did is we wanted basically to compare it with EMDR, but the EMDR people were not organized well enough in Israel to do that. So we compare it with prolonged exposure. The method that Edna Foa is from the University of Pennsylvania has proposed and has done a lot of research, and it's sort of a golden standard for therapy. It is also the treatment that we love to hate. And a lot of people say, oh, no, I don't want to do that. So we thought that would be a great comparison. And what we see until now, we're just finishing until the summer, we will have finished the full-fledged study. And what I expect is that there will not be a real difference in effects between the two. So that can really influence the field if we know that somatic experiencing is becoming an evidence-based therapy. Now, at the same time, also with somatic experiencing, we see the same, ceiling effect that we don't get past the 40% of people who get out of PTSD. So one of the questions that has come up is, well, maybe maybe this does not fit for people they have all the symptoms of PTSD, but it's based on moral injury. It's based on a conflict they have with what they have done, with what the army has done, or what they personally have done, or what they have not done and should have been able to do. And that whole issue of moral injury has come up as an important area of research. And one of our team, Dr. Anna Harwood Gross, has focused on that and has written several studies on that. And we're now also looking at, is that maybe one of the problems that all the therapies that are based on fear, on trying to get down the fear, is less effective for people whose problem is not fear, but problem is guilt and moral injury. So that is another field that we're looking at. We're also we thought that we would get into neurofeedback program. We have played with that a lot, but it's not an easy field to get into. We do in our MDMA study are doing an EEG study before and after the treatments, and are really curious to see what changes in the brain through our treatments. And the initial results I hear from the one who is doing that for us, that there are real changes to be seen in parallel to the symptoms going down and functioning going up. So these are all things that we are happy to share and look at how to basically have people in the world to adopt part of these insights that we have developed in the past many years.
We've got a fortune of questions about all of this stuff, so I'm just aware of the time, so I'm going to go through a few of them. Just going in more detail about the intensive programs. Just a question about the limits of the traditional 50-minute a weekly model, and what is it about intensive formats that help stack clients?
Yeah, I'm looking at our classical models of therapy, and as a sort of side hobby, I'm a bit of a strange person. I treat people who've been in ritual abuse or organized sadistic abuse, and have seen that our 50 minutes therapy are just not really relevant. So then I sometimes think, how did we think that 50 minutes or an hour a week or twice a week will solve all of the problems? So I've opened myself to other possibilities. I'm an extremist, so I have one client, a woman who's gone through the most horrific abuse that you imagine, organized with many men abusing her and things like that. And we came to an agreement that we agree when a therapy session starts, but she determines when the session is over. That can be an hour or an hour and a half. It can be 6 or 7 hours. And that is, I know it's quite extreme, but it's very effective. And so we have to look at ourselves and see, where do we stop ourselves from listening to what people need and not jumping to, like when I tell people about this, the first thing that comes up is countertransference. Aren't you over-involved? And all these kinds of reactions that that it's okay to ask, but we also have to see what fits, what can really help people with these very extreme kind of things they went through and these extreme dissociative features they then have to cope with. So we always are looking a bit out of the box, or for some people it's very far out of the box, to see how do we serve the people who need us in the best ways.
Yeah. And I know that you've worked, intensively also as a program for the Nova survivors, and I'm guessing there would also be some of the people who need the more intensive work. Just going back to the neurobiological changes, with someone just had a question about just wanting to know more about what those are in terms of survival mode. Could you just explain a little bit more about that?
So in survival mode, there are at least 4 mechanisms that change. One is we become very focused on whatever can be dangerous. So our whole system of how we know how to focus our attention becomes sort of automatic, and we're focused on anything that can mean danger. And that can go together with the classical fight, flight, or freeze. The second thing is, during survival mode, we are in a sort of dissociative state. When you talk with combat soldiers, they tell you, during combat, I didn't feel, I didn't think, I just did. And that is the basis of survival mode. Things fall off the side. You'd better not feel in order to survive. You'd better not think too much, but you have to just do. And then, of course, later comes the question, how do you integrate the thoughts and emotions? Because it's not that they don't exist, they are on the side. So then comes the question of integration. The third thing in survival mode is we learn very differently. During survival mode, we learn very effectively in ways that we don't know how to learn in any other situation. And that is why things are being imprinted in our memory and people get stuck with what they've seen. And that is that kind of learning that is very different from our regular learning. And the fourth thing I've mentioned already is the attachment during survival mode. You attach, and that goes through oxytocin. That is, besides the cuddle hormone, is also a stress hormone. So what we hear from in the groups of soldiers is things that you think, that's exaggerated. They say, I love my guys, my comrades more than I love my wife and my children. That's strange, right? But they feel this attachment, and the language doesn't really allow to find other words for it. It is a very intense and deep attachment. And the only word they find for it is love. But it is a traumatic bonding for safety, and it works very well. It's very important. So that is yet another aspect of survival mode. And all of that comes back when we have people with PTSD who need to be treated. And this attachment, of course, we also see in people who've been severely abused. And there's no other person in the room besides the perpetrator. And then you see this attachment to the perpetrator, which in the past has gotten all kinds of interpretations, like it's masochistic or things like that, or the death instinct, but it's also the very natural hormonal attachment reaction when you are in survival mode. So it's very much in the body.
Just aware of the time, so just one more question before we start to talk a little bit about the overseas intensive. Resilience is often spoken about not only as a recovery, but as a transformation. What does the post-traumatic growth that you mentioned at the beginning look like in individuals and communities? And what conditions make it more likely to emerge? And how does that link to the work you've done since October 7?
Yeah. So we've done a lot of work, especially with the soldiers, looking at post-traumatic growth. And what we've seen is that is one of the main measures that goes up in our Peace of Mind program. That people say, I know now what is important in life. I'll give you two short examples of participants. One of them, who was 28 years old when he came into the program with his unit, and everyone in the unit says, oh, he's a fantastic guy. He was still, at age 28, in security business, was a security guard or a supervisor of that, and his group said, if you need to go to whatever combat, you want only to do it with him. He sees and hears everything. And when I hear that, I say, oh, survival mode, right? That's when you are focused on danger. So he's very good at his work. And at the same time, they said he is wasting his life. Why is he still in security? Because he is a great chef. He's a very creative guy. And so what is he doing? What is he doing in this stupid work? It's not stupid, but it's waste for him. So 4 or 5 months after the end of the program, he called us proudly and said, I left security. I'm now in a training for internal design. And that is really the transition from survival mode to civilian mode, and growth and understanding what is it I want in life, what is important for me. Another guy.
It's a great example. Yeah.
Yeah, another guy who, after the army, learned to be an accountant and was making nice money. And during the program, he told us, I'm okay with what I'm doing, but it's not my passion. My passion is teaching children. And he actually left his job and started to be a teacher and found his passion. So all these kinds of things are parts of how do you find yourself? How do you find what is important for you? It's meaning making.
Mm-hmm.
And that is really, I'm proud of these kinds of examples.
Yes, definitely. We were hearing some of it last night at a Bet Halafem as a DVO function, actually. But we need to kind of segue into talking about the amazing overseas summer intensive, because we don't have a lot of time left. So just tell us a bit, like, why train in Israel? What can clinicians learn in Israel that's difficult to access in Australia? Why should they do the program? And how do the field visits and the community immersion deepen clinical understanding?
Yeah, to be honest, I can't really say what can you learn in Australia or wherever. I know what our experience is, and the people I'm working with. So we have had the opportunity to have to develop a lot of new methods,
Mm.
and that has one of our colleagues in the United States has called this finding the pearls in the disaster. So basically, sort of also post-traumatic growth, when we have seen what what the children are saying, and we are in a sort of a trauma lab here. Not that we want to be that, but now that we are, we'd better learn and use it for the future.
Yes.
So all these things that we have learned, we are happy to share and think, how can they be applied? We don't think that everything is as relevant for other communities, for other cultures. But there's a lot to be looked at. How do you boost resilience in communities? Now that your communities in Australia are exposed, and start thinking of, how do we do this? How do we keep ourselves together? What do we do with people who don't dare to come to the community centers? and how do we make it possible for people to feel empowered and not disempowered. So I think we have experienced a lot of that in our own lives, but also, in Israeli society.
Yeah, there's a lot of insider knowledge as well. In terms of the program, can you tell us a bit about the structure, the rhythm, and what are the competencies that participants can hope to gain from doing both the 2 weeks, but also if they choose to do the extra clinical week, what does that add to the whole picture?
Yeah. So basically, the course is a combination of really sharing the theories that we have found helpful in our work and the programs that we have developed um, and are putting out there. So it's on the one hand, there's a lot of theory. We always ask people to also look in their own lives and look at coping and how that works. Because once more, I'm saying this whole survival mode and how you get into it and how the art actually is, how do you allow yourself to get out of it? That is something that everyone has experienced in his or her life. So we think that that is an important tool also to look at and make people aware, because actually, at least when I studied psychology, trauma wasn't part of that, and the body wasn't part of that. And now things are changing, but they're changing slowly. And what we've seen in the courses we've done is that people really get it when you give them the opportunity to both hear the theories, but also apply it to what they've gone through themselves and really get that inner knowledge going.
Mm-hmm.
So there are, of course, it's every day. We start at 9 and go to 3:30 or 4:30. Very intensive. There's also a lot of literature that we share. And there is also a site visit to the south to hear from the work in the resilience centers in the south. Um, and at the same time, we always make sure that the groups also have some fun together. And that is very important because we have to stay regulated ourselves to be busy with this whole field. The third week is really a hands-on training of the combination of the three-phase model of trauma treatment with tools from cognitive behavioral therapy, but also a lot of somatic experiencing that really allows to get out of survival mode or calm yourself down and see how you can get rid of all that survival energy that gets stuck in our system. So that is a very practical, the third week is very, very practical.
Someone is asking about whether you have an assessment tool that you use to assess post-traumatic growth.
Yes, there's the PTGI, the Post-Traumatic Growth Inventory. Of course, we're happy to share all of these things in the course because we want the knowledge to be out there. And of course, we need to look at the 5 different areas of post-traumatic growth that Tedeschi has defined. But what do we do with that?
Mm-hmm. Right. We'd really like to now invite a past participant, Gabby, just to give a few reflections on her experience, if that's okay, Danny.
Sure.
I know it's nice for you to reconnect with her as well. She was
Yep.
actually in the last group. We were just talking before the webinar started, right before October 7th, so that summer. So Gabby, are you on? Just while they're getting her on, I'll just perhaps ask the first question. I think she's still on mute. No? All good. So Gabby, what drew you to the program and what surprised you the most? She's still on mute. Oh, Gabby, you have to unmute yourself. Oh, her computer's frozen, apparently. Maybe while we're just waiting for her, I might just ask you one more question and then go back to her just about when you think about the future of trauma treatment, what gives you the most hope?
Yeah, the paradoxical thing is that being in this work for the past 46 years, I always feel that it is an area where you can really do something. It's very it's very moving to see that by your full presence, your physical and mental presence with someone and being a witness to what people have gone through, which means you really need to be able to hear the gory details of what people
Yes, totally.
have gone through. Something happens and people start coming out of the most horrific situations. Very often, especially with these severe abuse cases, what you often see is functioning goes up, but at the same time, the difficulty with the memories does not go down. That happens later. So sometimes then you feel that maybe am I doing damage? Uh, um, but no, this is how things go. And so one of my patients who studied and finished studies and started to work, and at the same time, last week said something like, "It's it's becoming much harder to hold my memories." But the fact is that she didn't hold her memories. They were dissociated. And now that they're back, it is really not easy. So that is the paradox you see in this kind of work with very severe cases. But all in all, um, I must say that the work itself is very hopeful. And I've seen that also from Holocaust survivors and done research about Holocaust survivors. And it's amazing that they've built their families and their careers, and they carry a lot of pain, but they very often do that with dignity. Of course, not everyone, but uh, I've learned a lot about hope from this kind of work.
Really important.
Is Gabi back?
Apparently she's frozen at the moment. They're trying to get her back. So I'll just ask you one more question about to sort of lead people here. So what final message would you offer to the clinicians and community members who are listening to that today? And also, how can they stay connected with Metiv's work and learning opportunities, even if they don't end up coming for this summer intensive?
Yeah, so we have a mailing list you can subscribe to on our website, which is www.metiv.org. And we try to update our website, and it's always too late. But we try to do that, and yeah, the work at this moment is unending. Oh, here Gabby is back.
She's here.
Hello.
Here.
Sorry.
That's all right. So I'm going to throw all the questions into one.
Yeah.
So I want to just find out from you what first drew you to the program and what surprised you the most. What were the elements of the training that had the biggest impact on your practice when you got back? And how did Israel and being in Israel shift your understanding of trauma and resilience?
Okay. So I guess the first thing that really drew me to the program was really, I think it came up much earlier, is that there is no program in Australia quite like what the summer intensive program offers, especially for clinicians who have busy schedules, not really able necessarily to take sort of a day off here and there to go to, say, like a Blue Knot 2-day training. And I've always been sort of interested and sort of drawn to understanding on a deeper level, sort of working in the space of trauma. I'm a social worker for New South Wales Health, and at the time I'd already been working in the acute hospital setting for nearing 3 years, predominantly in the acute care space of neurosurgery, so supporting families of patients who had sort of severe acquired traumatic brain injuries, car accident victims, assault victims, but also catastrophic strokes and glioblastoma brain tumor diagnoses. So sort of a range of varying degrees of trauma. And I sort of felt that I wanted to enhance my practice even more. And when I started to look, I really couldn't find anything that would offer that level of intense training and sort of theory and professional development. And I'd had a few friends who had done the program previously over the years, who raved about the course and about the learning opportunities and the network of clinicians from around the world as well that you sort of get to meet and have the privilege from learning from as well. So that's sort of what drew me to the course. And I felt very lucky that I was able to get the time off from work to do that as well and use my leave to do that. So I do acknowledge it is sort of it's a 3 weeks, and I would recommend to any clinician sort of online who is thinking about doing the program to do the 3rd week. It really pulls everything together from the first 2 weeks of theory learning, so would highly recommend doing the 3rd week if you're sort of not sure if you want to do that or not. I guess since coming back, and I think that was your second question, Rina, as well. Sort of how have I applied that to my day-to-day practice? I still work in the acute hospital setting, just at a different hospital now in a different clinical area, and now work with predominantly dementia patients and sort of aged care patients. And I apply almost everything that I learnt from the program to my day-to-day practice and also just I think in life in general. Having the language and the knowledge base now to understand that the patients that I see in the hospital are actually experiencing an acute stress reaction or are in survival mode when they present to hospital, is so important to the way in which that I work day to day. And then also to be able to then support them and their family members in sort of understanding, that what they're feeling is normal. This is a normal reaction to a crisis or to a trauma, and looking at ways through which I can support them in developing skills in regulation. And I wouldn't be able to do that without having the privilege of learning from Danny and from everyone sort of that presented to us throughout the 3 weeks, because they all came with, worlds of knowledge and research behind them. And I guess since coming home as well, it sort of stemmed into more of a quality improvement project through work. So we recognized that, social workers in the acute hospital setting are often tasked with providing that crisis intervention response. And whilst the course really looked predominantly at that longevity of intervention and working with people over periods of time, everything that was learned is so adaptable to the acute hospital setting. And so I worked with my now former colleagues, but at the time my colleagues, on developing essentially a resource for social workers in the acute hospital setting to share this knowledge, to share this language, to sort of support in developing the skills of my colleagues around understanding survival mode and what we can do to support our patients and their families when they present to the hospital setting. And through that research, interestingly, for those of us here in Australia, statistically speaking, 75% of Australians will experience a potentially traumatic event in their lifetime, but only 11% will go on to develop PTSD. And so I think that really sort of, is what drove me and my team to put together this resource at work. But I do use it, everything that I've learned, the trauma vortex, the healing vortex, and I can't see Danny's face, because I'm on my phone now, but, everything, the psychoeducation, the language base is used every single day in practice. And I'm a better clinician because of the program. And I think, importantly as well, you don't, Danny is there, but we learn from all of the amazing clinicians and researchers at Metiv and Hebrew University. I still think about, to this day, what would Danny say, or what was that thing that Alon spoke to us about when he was teaching us about, what he does with veterans and the Peace of Mind program, or what was that paper that Sarit, mentioned about, strategies to support children, so yeah, it's a fantastic course, and I think if I could do it all over again, I would.
Gabby, I'm so glad. Obviously, you've got a fortune of knowledge. I'm so glad we all managed to get you in here to tell people about that. Just one very last question for Danny. People are just asking what level of experience do clinicians need to be at to do both the course and the clinical week? Obviously, Gabby's had, quite a bit of experience already before she came. So if you don't mind, Danny, just answering that, and then we'll bring it together.
Yes. So for the first 2 weeks, basically we say a first degree in anything like psychology, social work, expressive therapies, but also we've had rabbis, we've had chaplains. That is, the first 2 weeks is much broader than only mental health professionals. For the clinical week, we do require, a second degree in one of the helping professions and a basic knowledge of therapy already.
Thank you so
That is
much.
what I would do.
Thanks for clarifying that. Look, thank you, Toda. We really appreciate your wisdom, your clarity, your generosity. I know it's been a long one. So thank you. We really, really appreciate it, Danny. And thanks everyone for joining us tonight, and hoping that some of you will get the opportunity to do it this year. And if not, it's an annual program. So yes, it sounds incredible. Thank you, Danny.
And let's pray for better situations in the world, both for
Amen.
all of you, but certainly also for what is hanging over our heads right now. So we really need all the support we can get to get through the next thing that seems to be happening.
Yeah. And hopefully it's an hour of Nissim, of miracles. But in the meantime, take care of yourself, and wishing you
Thank you.
Chodesh Tov and a Shabbat Shalom.
Thank
Shabbat
you
Shalom,
very
everyone.
much to all of you. Shabbat Shalom.
Thank you.
Bye.
Thanks.
Thanks, Dr. Brom, and thank you, Rina, for such a thoughtful, was a really deeply meaningful conversation. I think everyone has gotten so much out of this webinar. We're incredibly grateful for the work that you do and for sharing your experience and wisdom with us tonight. It's so appreciated. Thank you also so much to Gabby for sharing your reflections. I think you really sold the program. So thank you. To everyone who's joined us, thank you for being part of this important conversation and for your thoughtful questions. We're sorry we couldn't answer all of them, but we hope we got to a few of them. If tonight has reinforced for you the value of building these skills and understanding in this area, we encourage you to learn more about the Trauma and Resilience short course. We'll be sending through the details in a post-event email along with the recording of this. So look out for that, and you can contact us with any questions or be put in touch with Gabby to find out more. This has been the first event in our new webinar series, the Impact Exchange, from Jerusalem to Australia, and we look forward to welcome you to future conversations. So look out for our details in our next webinar with Dr. Corey Schulman, who's a world-leading expert in autism and early childhood development, and she's director of the Autism Center at the Hebrew University of Jerusalem. Her groundbreaking research focuses on understanding developmental trajectories in children with autism, and she has pioneered innovative programs that support children with autism in mainstream classrooms. Thanks again. Thank you, really, Danny. That was incredible. Good night, everyone.